This study update or this analysis was presented at ASCO GU by Dr. John Nikitas, who is a radiation oncologist working with us at Nuclear Medicine, further highlighting the collaboration between radiation oncology and nuclear medicine here at UCLA. So this trial was an investigator-initiated trial using the potential upstaging effect of PSMA PET. PSMA PET can show disease that is unseen by conventional imaging modalities, CT, bone scan, even through cyclovine PET. So PSMA PET is currently the most sensitive imaging technique to show prostate cancer lesions. Of course, far from perfection, but I think the best we have. And so many people question whether this can actually improve outcomes or not. It's good to have a great diagnostic test, but how to use it at best, this remains unseen. And so this trial was designed to see how patients selected with PSMA PET to undergo definitive radiation therapy versus patients selected with conventional imaging, if there was a difference or not. And we accounted for a potential difference between 8 to 10% of upstaging, meaning disease seen outside of the pelvis in this initial staging setting. And this patient would therefore not get definitive radiation therapy because it's already too late. And so that's how the trial was designed. PSMA PET is basically victim of its own success. Very rapidly, this investigational test got a very rapid uptake from both the imaging community, the referring uro-oncologist community, and even the patients themselves. Already wanted to get PSMA PET even before FDA approval. So then the window to test such investigational tests in a trial setting really narrowed down very quickly because everybody was doing the test. So if you want to randomize patient to a control group, meaning patient to not get the test and being treated without, very rapidly it was getting more and more difficult because everybody wanted to get the test. And then, of course, you know, at UCLA, for example, we were using a cost recovery mechanism. So for a while, it was possible to get a PSMA PET either under clinical research protocol or to pay out of pocket for it. But as soon as it get FDA approved and the insurance covered the scan, then everybody could get the scan for that indication. So then no physicians or no patients would really want to be randomized to the control group anymore. And it took us some time to open the study. It was an investigator-initiated trial supported by Progenics, then Lantheus, after the acquisition of Progenics by Lantheus. So the PSMA PET tracer was PYL. They agreed to provide it 3 doses. We were able to randomize patients for about a year before the FDA approval in 2021, basically. And after that, recruitment became very difficult. Patient could get the scan outside of the research for the same indication and no longer wanted to be in the control group. So we could have kept the study open, but the dropout rate would have been significant in the control group. And ethically, financially, logistically, it was just not possible anymore to recruit patients because of the control arm. So it really questions how to design these trials based and powered for, you know, potential difference in outcomes of patients, whereas it's just a diagnostic test. And, you know, to show meaningful difference on outcomes, specifically in the upfront prostate cancer setting like that, it takes years, decades even. And so these trials are not easy to do because you will need decades to harvest mature data, whereas meanwhile you are able to establish the diagnostic efficacy superiority over the other imaging modality or over the other test, And so you are in this paradigm where you don't know if it really improves outcome, but we know that the test has a better diagnostic efficacy. But you cannot really do the trials anymore because the test is widely available and it's not easy. So this really highlights some, a little bit this contradiction about what we expect from a test, the way we want data for establishing guidelines and showing improved outcomes with a diagnostic test. It's not easy. Having said that now, so the trial closed at about 50 patients recruited. The sample size, based on our hypothesis of 8 to 10% upstaging, was 316 patients. So we're basically at, 50 on 300 patients needed. So we're very far from the target enrollment. So the study is completely underpowered. And of course, we were not able to show any difference. There was still a little bit of upstaging effect. 1 in 6 patients got some upstaging. It means that it shows some disease outside of the prostate that was unseen before. But, at the time of analysis, it was impossible to show any difference really because it's too early and too little number of patients. First, I want to thank the support from Progenics and Lantheus, who provided the tracer for free for these 50 patients. Then I want to say that we were able to start a similar study design, not in the initial staging setting, but in the salvage setting. And we were able to start that before. And so we were able to complete the enrollment. The study completed in 2020. The impact on management has just been published in European Urology. Happy to talk about that later in another session with pleasure. And we expect to harvest mature data in a year from now. So we were able to go sufficiently fast before FDA approval for the other setting, in the salvage setting. And then the third thing I want to say is that some colleagues in Europe may be able to open the trial on their side, and whoever is able to replicate, the similar study protocol somewhere, keep patients randomized to the control group without a PSMA PET scan, follow them. Maybe one day, we can merge data sets, and then we will reopen the study on our end just to follow up the current cohort, the 50 patients we have recruited. So if other sites can do that protocol at their institution, we can definitely merge data in, 3, 4, 5, 6 years from now, maybe to increase the N and the sample size.